are very pleased to invite our last speaker for this panel, Dr. Yfat. Dr. Cohen is a senior psychiatrist and psychotherapist, the founder and director of Public Institute, the first and largest DBT center in Israel. Dr. Cohen was trained in DBT by Marsha Linehan during her clinical and research fellowship at Brown University. She serves as the director of a public mental health center for 10 years. And in the past years, directed dozens of DBT workshops in the public as well as the private mental health domain. She's also provided training for residents in group psychotherapy for children and adolescents for the past 24 years in the Sakla School of Medicine in Tel Aviv University. Dr. Cohen, invited.
Thanks, Dana, for inviting me to this interesting and important panel. It's interesting to see that the main or the most the therapy that actually has similarities mostly is the transverse focus therapy, and that's interesting because DBT stems from behavior therapy, not even CBT, but behavior therapy, and so I think it means something. It means we need some dialectics, right? So I did find that, which things that I knew before, that even Kernberg himself realized that you need some order, some systematic working in order to work with the borderline patients. So as I said, DBT stems from the behavior therapy, and I'll say in a minute who founded it, who developed it. Let's look at the abbreviations. The dialectical stands for dialectical philosophy, which is a philosophical philosophy that Hegel, from the late 18th century, beginning of the 19th century, talked about, and is very much known, and basically talks about the non-existence of absolute truth and the need for synthesis of opposite forces. And in therapy, the opposite forces, the main opposite forces that need to be synthesized is the opposing forces between acceptance and change, which mainly is something we have in each therapy, but here we do have a philosophical stance and understanding that helps us think about it. The behavior task is more readily understandable, setting goals like we do in CBT, skills training, we talk about skills deficit, and solving problems in a systematic way. The third part of it is the therapy itself, the therapeutic relationship, the relational task, which I think my colleagues talked about it in other therapies, but it's very, very much accentuated in DBT, the therapeutic atmosphere, building the strong and positive therapeutic relationship in order to contain the conflicting, opposing forces, in order to set a validating atmosphere, and which is crucial to these vulnerable, multi-problematic patients. So if we look a little bit at the past history of DBT, which has a quite distinguished past history, it was developed by Marsha Linehan in the late 80s of the previous century. Marsha Linehan is a professor of psychology from Washington University in Seattle, and she actually was interested in treating refractory treatment refractory suicidal adult women mostly. And since she needed a grant, a federal grant, so she was asked for finding a diagnosis, and then it was found many of the patients actually answered the diagnosis of borderline personality disorder. And she actually did some trial and error approach and found that focusing on solving problems was experienced as invalid by these patients. And when she switched 180 degrees to warmth and acceptance, it was as well experienced as frustrating because they felt that it didn't help them to solve their problems. So the solution was a combination, and the philosophy of the combination is the dialectical philosophy, which actually combines this acceptance and change. So in 1991 was the first randomized controlled trials by Linehan and her colleagues, and they actually included in this first research the most refractory patients, the most treatment-resistant, suicidal, highly suicidal patients, and it was quite promising, and I'll show you later some other many RCTs that were carried on, that were done since then. 1993, the first book and skills manual that accompanied the book. And on the back of this book, some reviews you have on the back of books. So on the back of this first book, it's written that very seldom there is a therapy approach that makes sense to the patient as well as to the therapist. And this is not a trivial thing, and I think that this is one of the attractive or beneficial or positive things in DBT. And you can say that DBT is the gold standard by many APA and other organizations, gold standard for treatment of suicidal borderline patient. It's good that it's not the only one, maybe, but it's the gold standard and has the most research on it. The overarching DBT goal is creating a life worth living. This goal itself is very validating for patients who usually suffer from criticism by therapists and mostly, as you pointed out, Professor Gurry, about what balances the basic fault. They do have a lot. I find it very, I agree with it, that they feel self-hatred, they feel they have a basic fault, and when you don't blame them for this, as many feel, and you invite them to to participate in a therapy that create a life worth living, it really, I see how it makes them feel understood. Because what we say, and maybe it needs to be said because I didn't hear it from my colleagues, the main thing is that these borderline patients suffer a great deal. They really, life for them is an everyday struggle. And there I saw once a to-do list of a borderline patient is wake up, survive, go to bed. So I think that this is, from the patients that I see, and I see a lot of them for many years, that's really something very prominent in their life. So according to DBT, the borderline personality disorder is seen as a pervasive dysfunction of emotion regulation system. That's the way that Linehan puts it. And the theory behind it is the biosocial theory of borderline personality disorder, which has lots of support to it, and it combines the biological etiology, the emotional dysfunction, that talks about the vulnerability and the intense emotions, and in transaction with the invalidating environment, the environment that includes abuse and ignores and criticizes and different kinds of invalidating experience that that these people experience through their life. Okay, so what are the core features of DBT? The CBT is the most obvious one, and then the things that actually make DBT quite revolutionary and very innovative, to my opinion, therapy is the combination between mindfulness and the dialectical philosophy. I don't have time to go into the details, but mindfulness is not only a skill, it's also a stance of the therapist, meaning non-judgmental, observing in the here and now. Other than that, we do have a systematic approach. It's a principle-based, not a protocol-based. Only the groups are based on protocols. The individual therapy is based on principles, clear basic assumption, and one that is very unique to DBT is the specific focusing on suicidal behavior. Each session starts with the question, did you hurt yourself this week? Okay, we do have, well, I'll skip this. The format, the treatment modes include a primary therapist and patient, as we've seen most of the therapies. But in addition to that, the skills training, which is done in groups, the consultation meeting for therapists on a regular basis every week, which is very important, as Marshallina says. If you don't have a consultation team, it's not DBT. And what we added in OFEC Center is parent skill training that we actually developed. So the goals, the hierarchy of goals, it's always in this order, very clear goals, reduction of life-threatening behavior, that's the first goal. We can also call it motivation. Motivation for life is the first goal. Motivation for therapy is the second goal, which is reduction of therapy interfering behaviors. And the third goal is reduction of quality of life interfering behavior. And these are the goals of group skills training. These modules, as we call them, the core mindfulness skills, interpersonal skills, emotion regulation skills, and distress tolerance skills. The core strategies is validation, which is the most important strategy, and actually it has some similarities with the clarification, confrontation, and interpretation, because we have 6 stages, of validation, which include, in many ways, the one you talked about, but in dialectics with problem solving. So validation for acceptance and problem solving for change in a dialectical way between them. There are more than 35 RCTs, okay, in more than 30 countries, independent groups, many settings, different populations, and the outcome are quite consistent in some things like the reduction of suicidal behavior, non-suicidal self-injury behavior, substance abuse. The dropout for treatment is also very low in DBT. It's only around 20-25%, and we see the same percentage in our center. And there are few studies about cost effectiveness, which shows also benefit in this area. So why is it good for the public mental health? Because it's evidence-based, very strongly, heavily evidence-based. It's effective, very effective with the kind of patient that we see in public outpatient, in public also in inpatient. It saves a lot of money, and it's meant for team work, okay? And it says that it has less burnout of therapists. I'm not sure about that. So 1 minute just about the implementation, because I promised some things about the implementation and dissemination of DBT in Israel. Basically, we started around 2000. We did an intensive training, 5 days of intensive training for many people in the Ministry of Health, and thereafter we actually work with many outpatient teams, and not only in the Ministry of Health, but also in the social services, education services. DBT for me is kind of a language, very much validating and effective language, and has a very strong, as I said, evidence. So, thank you.